My name's Navin Pinto. I'm a pediatric oncologist. I'm a professor of pediatrics at the University of Colorado's Anschutz medical campus in the Denver metro. And I'm an attending physician at Colorado Children's Hospital. And my work within pediatric oncology largely focuses on the care of patients with neuroblastoma. Neuroblastoma is a rare malignancy that affects about 600 or 700 kids per year in the United States. And a subset of those patients have what's called high-risk neuroblastoma, which is a very aggressive disease that usually metastasizes and currently has relatively poor cure rates. So we're constantly looking for better, less toxic therapies to improve those outcomes. Much of what I do on a day-to-day basis is work within the Children's Oncology Group. The Children's Oncology Group has just celebrated its 25th anniversary, so it was founded in the year 2000, and it is what's called a cooperative group. So we learned long ago, basically when chemotherapies were first implemented for cancers, many of those cancers were pediatric cancers that were first treated with chemotherapy. And the doctors that instituted those trials learned that because of the rarity of childhood cancer in general, then when you start to split it into diseases like neuroblastoma, these things become ultra rare. And even very large centers may only see a handful of cases of a given childhood cancer at their center. And so very early on, academic medical centers started to work within what are called cooperative groups, where they ran clinical trials together as a network. And so whether you were diagnosed in Boston or Loma Linda or Peoria, Illinois, your treatment would likely be the same, and you may be offered treatment on a clinical trial trying to improve outcomes. And the biggest cooperative group for childhood cancer in the world is the Children's Oncology Group. That's run primarily out of academic medical centers in North America, so the US and Canada. And there are also sites in Australia, New Zealand, and other countries internationally. So there's about 250 hospitals that participate in Children's Oncology Group's clinical trials, about 7,500 healthcare professionals that are a part of the Children's Oncology Group. I think across the board, the most common malignancy that we see as pediatric oncologists is acute lymphoblastic leukemia. And really, over the lifespan of the Children's Oncology Group, we've brought the cure rates for this most common malignancy, ALL, well above the 95% mark. So really incremental improvements in cure. And I think actually one of probably the most landmark studies is a very recent study that showed that the addition of an immunotherapeutic agent, blinatumomab, improved outcomes for patients with ALL considerably. Within my world, there's been also several landmark studies for neuroblastoma within the Children's Oncology Group, mostly that intensification of therapy and the addition of immunotherapies have improved outcomes. So on the intensification side, we've done several trials that have randomized patients to an intensive course or two of high-dose chemotherapy with a patient's own bone marrow or peripheral blood stem cells being used to rescue them from the toxic effects of that high-dose therapy. So we did a randomized trial early on that showed that using standard dose chemotherapy was inferior to high dose chemotherapy with stem cell rescue. And then in the early days of the Children's Oncology Group, my colleague Julie Park ran a study where 2 cycles of that high dose chemotherapy were compared to 1. We call that Tandem transplant, and the Tandem transplant cycle 1. So that was a pretty considerable improvement in outcome by incorporating 2 high dose cycles of chemotherapy. And then on the immunotherapeutic side, neuroblastoma was actually one of the very first malignancies in pediatrics to incorporate an immunotherapeutic agent. Immunotherapy is a very hot topic across cancer writ large, and there are many malignancies now that are treated with immunotherapy only approaches. But neuroblastoma in the early 2000s was one of the first cancers to be treated with a monoclonal antibody. That antibody is now called dinutuximab. And it's also one of the few examples of a drug being FDA approved for a pediatric only indication. Most of the drugs that I prescribe in my clinic are drugs that have been studied in adult oncology as well and may have an FDA approval in an adult indication like lung or colon or breast cancer. And we sort of recycle them within the pediatric space. But dinutuximab is a pediatric only indication for neuroblastoma. So that's another big landmark study. The landscape has changed that I think most centers now sort of follow this children's oncology group standard of incorporating 2 cycles of high-dose chemotherapy and incorporating immunotherapy into treatment. And I would say that how that's changed the landscape is that those interventions require sort of highly specialized care. The high-dose chemotherapy with stem cell rescue usually involves the coordination and care from a bone marrow transplant team. And so that sometimes does involve families having to travel from smaller centers to larger tertiary or quaternary centers for that ultra specialized care. And similarly for the immunotherapy, I think, especially in the early days, this was a relatively toxic drug with a lot of unique side effects, most notably pain. So it's one of the few drugs that we administer to patients that actually actively causes pain. And so sort of learning a skill set of how to manage kids through that rough, very toxic treatment, we've gotten much better at it now, and it's luckily much more tolerable for kids with an increased knowledge base. But I think that's really shifted the landscape in terms of developing that knowledge base and comfort with these incredibly toxic therapies. And I think it's also heightened everyone's realization that we have to work harder to try and find therapies that might not be as toxic, that might be just as effective, but don't have the terrible side effects of transplant or the terrible pain that might be associated with immunotherapy. I think the community at large, we knew what we were getting into. We knew that tandem transplant was going to be more toxic than a single transplant. It's always the challenge, right? We are faced with a malignancy where at the time, 30 to 40% of patients were cured, and we increased that to 50% with these interventions, but at the cost of increased toxicity. So obviously, there are more people walking this earth now as a result of these children's oncology group trials. So that's a big win. But, we hear from those patients and families that the toll of those intensive therapeutics is there, that people have organ dysfunction, chronic health conditions that result from these toxic interventions. So our goal as sort of the next generation of physicians involved in planning trials is to maintain and exceed our outcomes. We want to cure more kids with neuroblastoma and childhood cancer at large, but we want to do it with smarter therapies that don't take as big of a toll on patients. These advancements in pediatric oncology across the board would not be possible without a cooperative group like the Children's Oncology Group. I'm at a large academic medical center. We're a quaternary care, so other tertiary medical centers send patients to us. We serve really the Mountain West region of the United States. We're one of the only freestanding children's hospitals in this region. And so we have a large 7-state catchment area. And even if we said as a big, quote unquote, pediatric oncology center that we were going to go it alone and do it the Colorado way to treat leukemia or neuroblastoma or brain tumors, it would take us a decade or more to run a trial with just our population of patients. I'm a busy neuroblastoma referral center, and we might see 10 patients with neuroblastoma in a year. And so that's in pretty stark contrast to our adult colleagues across the street who might see 1,000 patients with breast cancer or colon cancer. and really can then develop an institutional way of treating this disease and advance therapies in that way. And that's why you hear so much more about things like second opinions within adult oncology, is that if you're seen in Denver, it may be reasonable to go get an opinion in Houston or New York to see how they're doing it. But within the children's oncology group, because these diseases are so rare, many centers, large centers, are doing this the same. And that's so we can advance our knowledge faster. I think with very few exceptions, the cure rates for childhood cancer are considerably higher than they were 25 years ago. So really across the board, liquid malignancies like leukemias and lymphomas, brain tumors, and what I deal with, solid tumors like neuroblastoma, we've improved outcomes. More people have survived as a result of the children's oncology group than I think would have without them. So I think that's a huge plus. I think, looking forward to the next 25 years, and hopefully we'll get these answers sooner than 25 years from now, is can we continue this trend? If you look by 5-year increments, the cure rates just go up and up and up. Can we do that with smarter therapies, with more targeted therapies, with therapies that don't have a long-term toll on the patient? I think the first 25 years of the Children's Oncology Group was dominated by an ethos that more is better. And that got us to this point that adding more intensifying therapies, largely through chemotherapeutics, improved outcomes. I think we've probably reached the max of that approach. And we understand so much more about the genetic underpinnings, the protein landscape, the interactions between tumor and the immune system now, that I think it's the time that we can start to exploit that knowledge to develop smarter therapies. I think one of the frustrations of dealing in rare diseases like childhood cancer is the rarity of these tumors. And rare diseases oftentimes take a very long time to understand if an intervention is making a difference. And so in solid tumors and neuroblastoma in particular, the sort of benchmark of what we look at to see if a given intervention on a clinical trial is making a difference is something called event-free survival. And we typically look at the 3-year mark. So basically what we're asking is, are the patients on the experimental arm, is their likelihood of having an event, most of those events are relapses, lower than our current standard of care? And if we can show that less patients have a relapse or progress on therapy, that intervention is active, is doing something against the cancer. But because of the rarity of these diseases, most of our big clinical trials, for instance, in neuroblastoma, may take 5 years to get the number of patients that we need to say we want to compare A to B. And then they require 3 years of follow-up from that. So typically 8 or 9 years before we have a readout. So for instance, one of the seminal Children's Oncology Group clinical trials that I mentioned was 0532. That is a code that was given to the study when it was first designed. And to break the code for families, the first 2 numbers, 05, is the year that study was first conceptualized. So 2005. The next number, 3, is the phase of the study. A phase 3 study is a sort of standard of care defining study, usually a randomized trial where the current standard of care is compared to an experimental arm that hopefully will define a new standard of care. And then the last number is the number of study that was in that year. So 0532 was the second study developed in 2005. That study activated not in 2005, but in 2007, and I believe read out in 2016 or 17. So about 10 years after it was first instituted. Painfully slow, did define a new standard of care, has improved outcomes. And so I think that's another thing that we're hoping to look forward to for the next 25 years is how can we increase collaboration, for instance, with international groups. The next largest cooperative group in the world is called the SIOPEN in neuroblastoma, SIOPEN. And we're trying to work with them. So we're not copycatting each other's studies, that we don't necessarily have to prove that a given therapy improves outcomes in Europe, just like it did in North America. Or how can we do studies that complement each other rather than compete with each other? And so we're working to try and shorten that timeline, but part of it is driven by how rare these diseases are. At the risk of getting too political, I think that one of the challenges that we face looking forward in the next 5 to 10 years are cuts to federal funding for clinical research. And so, as many people that might listen to this know, in 2025, there was a 40% cut to the budget of the National Cancer Institute, sort of across the board. And right now, currently, it's a little early to know how that may affect pediatric oncology. But a smaller cooperative group, the Pediatric Brain Tumor Consortium, was just nixed. It folded as a result of these budget cuts, and there, I believe, were 7 active clinical trials that network was running for patients with brain tumors that no longer will be allowed to enroll patients, and so we may not get a readout from many of those trials. We expect that the Children's Oncology Group will face budget shortfalls, and that will limit our ability to run the same number of trials that we've run historically. And so I think for families and patients where this hits close to home, I think just urging your legislators that the importance of funding to the National Cancer Institute. This cancer treatment doesn't think about a person's politics or their leanings in one way or the other. I just treat patients, and having that ability cut is very scary. And these interventions that have improved outcomes aren't giving patients a few more months of life, or they have the opportunity to give people 70, 80, 90 more years of life. And so there's sort of return on investment on doing clinical research in pediatric oncology is huge. And so, again, I think that would be my plea, is just to put out the signal that, this type of research is under threat, and that talking to your legislators may have an impact. The National Comprehensive Cancer Network is a network of academic medical centers that have been designated centers of excellence by the National Cancer Institute. And they get together to also make recommendations on what is the standard of care for a given malignancy. And luckily, now in 2025, we've started to roll out NCCN guidelines for pediatric malignancies. Largely, these were driven by adult malignancies, but now we have enough data for pediatric malignancies like neuroblastoma and acute lymphoblastic leukemia that the NCCN is developing sort of standard of care guidelines, where these academic medical centers review the data, and for studies that have a large level of evidence to support a given treatment, the NCCN will make recommendations. So I think of the Children's Oncology Group as running the trials and putting out the results, but not necessarily then making a recommendation on what is the best therapy when these trials are either not available, or for centers without the trials, or for countries that don't participate in the Children's Oncology Group. Many people look to North America and the United States, Brazil, Latin America, parts of Europe are saying, what is the Children's Oncology Group doing? And that's how I'm going to treat my patient. So the Children's Oncology Group runs those trials, and the National Comprehensive Cancer Network reviews the data behind those trials to make recommendations. So they sort of work hand in hand. There's a couple of takeaways. First is that for patients and families, often research may have sort of a negative connotation of being a guinea pig or a lab rat, or that there's going to be some really dramatic change from the standard of care by participating in a research study. And one of the both benefits and sometimes frustrations of working within the cooperative groups is that these are very small incremental studies. So these are not radical, by and large, shifts of our treatment paradigms. They are very small incremental changes. And there's a strong body of research that actually shows that patients that participate on clinical trials actually have better outcomes, even if they're getting the standard treatment. So many of these trials in the children's oncology group are comparing our current standard to a slight iteration on that, what's called the experimental arm. So if you're getting the standard of care and you compare those patients treated who are getting standard of care off study, the patients on study, even though they're getting identical therapy on paper, have better outcomes. And that's because I think there are guardrails around when you can start your next round of chemotherapy. There are research nurses and research coordinators who are looking at the data generated by those patients and making sure that these patients proceed with their next round of treatment, for instance, in a safe manner. So I think that's one takeaway for families is that this research is relatively conservative. It's not radical changes. And there are benefits to patients in participating in those, even if you're not getting the new drug that's on the experimental arm. I think the other thing that is important for families to know is that the Children's Oncology Group is out there, right? That there are some smaller centers that may not participate in children's oncology group studies. And so, again, I mentioned that by and large in pediatric oncology, the standard of care is dictated by children's oncology group studies. But for patients to know is that these studies are out there, and there may be a new study that a child or a loved one may be eligible for. So I think for families that may be just entering into this space, one thing to always consider is there a clinical trial for my child or my disease that I could hear more about? And sometimes that may be open at the center you're being treated at. Again, Children's Oncology Group covers the vast majority of children's hospitals in the United States, but sometimes it may not be open or it may require getting a second opinion to hear about any active clinical trials that are going on. And like I mentioned, there may be benefits to participating in clinical trials, even if you're not getting any new or experimental treatments as part of that trial. Then finally, I think another big piece of and big benefit of the Children's Oncology Group that we have benefited from greatly in the research community is the ability to do what's called biobanking. So many children that participate in clinical trials through the Children's Oncology Group have the opportunity to send leftover tumor specimens from a biopsy to a central repository where researchers like me can say, I want to study the last 100 patients with neuroblastoma that spread to the bone marrow, and I want to try and understand how neuroblastoma spreads to the bone marrow. Those specimens exist in a central repository that the Children's Oncology Group manages and allows researchers to ask really important questions that are driving the next generation of therapies. And so even if there may not be a clinical trial that a loved one is eligible for, this biobanking protocol is open for most children with cancer. And so that's another thing that families can consider is, can I send leftover tumor tissue, which usually just sits on a shelf and collects dust once the doctors have made the diagnosis, to this research biobank where doctors like me can learn from those tumors.